Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe to learn and grow daily. Now we're going to discuss the ITP. The ITP is expanded as the immune mediated thrombocytopenic purpura. So this ITP, first we'll be looking at the etiology. Next we'll have a note on the pathogenesis as well as the clinical features, followed by the investigations, and then we also have the treatment. So these are the aspects which are going to see them. And so first comes the etiology. So before we go to the etiology, this ITP, the older names, that is, it is also known as the Verholf disease. And specifically this ITP, it is not seen in case of the children. Now let's look at the etiology. There can be a primary etiology or a secondary etiology. Secondary etiology can be associated with conditions such as the SLE, as well as the RA, as well as the H. pylori. Next, there is also the HIV, and then comes the HCV. Now let's move on to the pathogenesis. So here in the pathogenesis of ITP, the immune, that is, we have the IgG. The IgG mediated destruction of the platelets. So IgG destruction of the platelets. Now the antibodies is against the GP2B, 3A, and the 1B9. So there's inhibition of the platelet release from the inhibition of the platelet release from the megakaryocytes. Now let's move on to the clinically. What do we see? The clinical features. The clinical features of the ITP is that there is going to be the mucocutaneous bleeding. So mucocutaneous bleed is what is seen, and this is with the low platelet count. There is a low platelet count that is less than 20,000. There can be petechiae, hemorrhages. There is presence of petechiae. There can be purpura. There can be ecchymosis. So all this can be seen, as well as moving on to the investigations. So these are some common findings. Upon investigations, we have the PS, that's the peripheral smear investigation. So we have the peripheral smear, and peripheral smear, it has normal findings like RBC, WBC, and they can also present with a few giant platelets. Next investigation will be the Coombs test. So what happens in the Coombs test? The Coombs test, it is mainly done in the Evans syndrome, which is again rare, and it is common variable immunodeficiency plus the thrombocytopenia. Now moving on to the bone marrow. On the bone marrow, there is megakaryocytes and precursors increase in number. There is going to be the megakaryocytes. Now where is this done? So this is done in case of the atypical findings. So this is done in terms of the atypical findings, such as splenomegaly, or in case of the first episode being greater than 60 years, or in case of the steroids. The steroids, it completely fails. So in such cases, this is done. Now moving on to some features, to add on to some features of this. There can be presence of fever. There is presence of fever. There can be jaundice. There can be subconjunctival hemorrhage and bleeding of the joints, splenomegaly, as well as the lymphadenopathy. There can be predominant giant platelets, as we discussed, the red cell morphology abnormality. So there can be the red cell abnormality. Then comes the WBC abnormality as well. So red cell abnormality as well as the WBC abnormality. Now let's classify this disorder, the ITP. So classification is based on the duration. So in case of less than 3 months, we call it the newly diagnosed. Then moving on to the 3 to 12 months, we call it the persistent. Then moving on to greater than 1 year, this is known as the chronic type. Now let's move on to the treating this ITP. So treatment of ITP, the goal will be to increase the platelet count to, increase the platelet count to about 30,000. So increase the platelet count to about 30,000. And if the platelet count is greater than 30,000, so in case it goes to greater than 30,000, so when it goes greater than 30,000, you wait and watch. And if it is less than 30,000 is where you have to treat it. So children is a self-limiting source. Now the same aspect when you see it in adults, what is the difference? So when you look at the treatment in adults, the first line will be the steroids. The first line is going to be steroids. That is, we can administer oral prednisolone. The oral prednisolone is what is given. And plus or minus, we can also administer the IVIG, the anti-D, plus or minus IVIG, the anti-D. So where are these indicated? The indication is surgery, life-threatening bleeding, and platelets less than 10,000 in case of life-threatening bleeding or in case of surgery and relapse. So what is the mechanism? The mechanism is that the anti-D. Mechanism of action is that the anti-D. It binds with that of the Rh antigen. So this Rh antigen it binds with and preferentially taken up by the spleen. So it is taken up by the spleen. Next is we also have the prerequisite. The prerequisite, it includes the presence of the spleen and also the hemoglobin. So hemoglobin should always be greater than the 10 milligram per dl. This is one of the aspects. So the first line, as we saw, it was a steroid plus the IVIG anti-D, and the steroid we used was the prednisolone and full dose into 2 weeks, and then you taper it. Next we move on to the second line treatment. So in terms of the second line treatment, you have the rituximab as well as the dexamethasone. So rituximab plus the dexamethasone. So this is the treatment which will be given. Then the thrombopoietin analog as well as the eltrobopac. So these are the other drugs, and the romiplostin. So these are the other drugs which can be administered. Next, you can also, in case of complication, there is the splenectomy is done. The splenectomy is done but can lead to complications, as well as the azathioprine. Azathioprine can be given. So follow-up will be the rise in counts in about 2 to 4 days. 2 to 4 days there will be a rise in count. So this was all about the ITP, that is nothing but the immune mediated thrombocytopenic purpura. To watch more videos like these and grow daily, subscribe to the Dr. Hub channel.